She is a university rank holder during 2015. She has received a recipient of TOSA award during the year 2017 and 18 for the best clinical innovation Pearl article and recipient of third prize for the clinical category in the 55th IUC. She had published several national and international publications and the author of 2 textbooks. So I welcome you, ma'am.
Thank you, sir. Thank you very much, sir. Good afternoon to all. Let me first of all thank the scientific committee for giving me this opportunity to do a presentation. I also want to thank my HOD, sir. The reason why I'm standing here confidently is because of the support and guidance I have received from my sir, Dr. Vishwas. The topic of my presentation is a guide to AI in orthodontics. Now, basically, artificial intelligence is defined as a system's ability to interpret external data, to learn from that data, and to use those learnings to achieve specific goals and tasks through flexible adaptation. Please look at this article. The name of this article is Siri Siri in my hand, who's the fairest in the land. The article is very informative, just as how the title is very impressive. Now, going to the historic background, although it started way back in 1940s, it took its turning point only with the issue of the first global report by the WHO. Now, this global report, it is actually a guideline as how to maximize the benefits of AI, reduce its risk, and avoid its pitfalls. By God's grace, I was able to attend a multidisciplinary lecture series from the Harvard School of Dental Medicine. The topic was A Clinician's Guide to AI. So my presentation would be based on this lecture series. So now let's go to the paradigm in AI. Symbolic AI is a method where we use machine learning algorithm in a way where a human readable symbolic manner. But now the current trend is machine learning, where the way how you solve a problem, the way how you tackle a problem, it shifts from how you solve the problem to how you read and interpret and learn data. Now, the problem with machine learning is that the information is limited to the time the machine was formed. So you have to keep updating the system to make sure that the information is correct and current. Next is the types of learning pattern based on the design of the algorithm. There are basically 3 types of learning. One is supervised, unsupervised, and reinforced learning. A very good example for supervised learning is the email spam detection. It actually works with a feedback mechanism and the outcome is actually known. Now, when we come to unsupervised learning, the outcome is not known. You can give a very good example is like you give a data to the system and the system learns from the data and it organizes into groups. For example, if you search in the net, something you put in the net, then after you'll be noticing that even in your social media, your Instagram and Facebook, even if you're not searching for those type of things, but something similar to those search will be seen in your social media also. So that is how the corporate company, they learn the data and they organize and make you into groups based on similarities, based on your age, sex, likings and demographics. So that is unsupervised learning. The next is reinforced learning. This is also called as reward system. Now, a good example for reinforced learning is the chess engine. Now, you do certain moves and what happens is the system interprets it and it rewards you as you're winning or you're losing the game. So that is the basic design of the algorithm. Now, when we do AI studies in orthodontics, basically it is of 3 types: diagnostic model based study, predictive model based study, and generative model based study. Now, if you see all the diagnostic models like radiographs, photographs, scanning, MRI and ultrasound, they all fall in diagnostic modeling. Whereas certain clinical parameters and diagnostic procedural codes, they fall in predictive modeling. Whereas certain clinical notes and articles, they fall in generative modeling. Now, diagnostic modeling is based on computer vision. Now, the computer fractionates the images without losing important factors, and it is able to identify the anatomic structures and the associated pathologies, and it can interpret it in the way how it is being taught, the learned pattern. For example, you give a radiographic image of a periodontal lesion. So the system, it understands, it can even detect the amount of bone loss that is present, and it can give you the diagnosis of periodontal lesion which needs flap surgery. Even that much, even your treatment plan it can suggest. But in all these, the clinicians say would be final. Next is predictive modeling. Now in predictive modeling, it goes like this: if-then statements. Like if a certain criteria is present, then the corresponding action should take place. For example, let's take a pattern like this. You have a series of pink boy and a blue boy. Now this pink boy with spade, pink boy with club. So this is the learned pattern. So how do we interpret in predictive modeling is, if it is a club, yes, then it should be a pink boy. If it is not, then it should be a spade. Yes, if it is spade, then it should be a pink boy. If it's no, then it should be a blue boy. So this is how there will be a basic learned pattern, and from that learned pattern, we predict the outcomes. Next, this predictive modeling, it has been used in various situations like predicting about the tooth loss, periodontitis, peri-implantitis, and survival with oral cancer. And the last type of model-based studies is generative modeling. Now, how this happens is, you give a data to the system, and when it is prompted, the system can generate its own answers. A very good example is the ChatGPT app. For example, you give a sentence to this app, like you just tell, my tooth hurts, why do you think so? Then it will interpret its own answers. It will say, tooth pain could be because of many reasons, and while I cannot diagnose, I can give you some reasons why you have toothache. Could be due to cavities, gum disease, abscess, or fractured tooth, or sensitive teeth. Now let's analyze all these reasons. Now you can see that 2 is relevant, 2 is irrelevant, and 1 could be 50% relevant and irrelevant. So generative AI can actually hallucinate fabricated information and present it as factual. So all these model-based studies, they have certain advantages, and along with that we also have certain disadvantages, which means we should not just base on artificial intelligence. Definitely a factor of human intelligence holds the major portion in it. Next is the major machine learning algorithms which we commonly use in orthodontics are decision tree, Naive-Bayes, neural network, support vector machine, genetic algorithm, and fuzzy logic. Now with this basic idea, let's go to the implications of AI in orthodontics. You can see that clinical assistance, diagnosis, and orthodontic treatment is possible with AI. So step by step, starting with growth analyzer. With the help of your hand-wrist radiograph, even your lateral ceph radiograph, you can predict the amount of growth that is present in the patient. Now Hatterskock et al., they took a lateral ceph, and this is how they plotted the points in the lateral ceph, and they tried to mimic the human neural network. They created an artificial neural network by mimicking the human neural network, and there were 24 models, and out of the 24 models, they noticed that the ANN model 7 had an accuracy of 0.9 in growth determination, and for gender determination it was 0.8. So next is growth predictor. Now what if a patient comes and asks us, I am a class 3 patient, how will I remain? Should I do a treatment right now, or should I just remain like this? So for the answer for this, the AI studies that is being done is, Tanya, she did a study where she analyzed the mandibular morphology of class 1, 2, and 3 patients. She did it with ANN and support vector regression methods, and she found that the manual method compared with the ANN and support vector machine, the ANN had a better hold. There was 0.8 coefficient of accuracy compared with support vector regression. Next is congenital genetic disease. Now, this is very important because we orthodontists we come across many patients with congenital genetic disease having is of all orthodontic interest. Now, this mobile phone app, Phase 2 Gene, is just very simple. You just have to click the photo of the patient, upload it into the app, and you will be getting the diagnosis, what type of a syndrome the patient is having. Now, this results given by this app has already proved superior in Asians and Caucasians and outperform humans in diagnosing what type of a syndrome the patient is having. Next is adenoids. Now, the study done by Yan and Rao. Now, what they did is they wanted to automatically diagnose the adenoids. Now, you can see the right side lateral ceph. These are the key point annotations that will be noted. And here we have a series of lateral ceph. These are the 5 models that they had compared, and they noted that the ADNET model was very perfect in identifying and diagnosing the adenoids. Next is TMJO classification. This is very important because only if you classify your osteoarthritis, your treatment also would be dependent on the type of osteoarthritis the patient is having. So now this study was done by Shaukri. Now they tested the shape analysis by using artificial biomarkers, and they noted the variations in the protein expression level, the surface of the condyle, as well as the clinical system. You can see the variables, the clinical and biological variables that was collected from the serum and the saliva, and they proved that the classification of TMJ osteoarthritis was possible with artificial neural network. Next is cephalometrics. I'm sure that you will all agree with me that the time-consuming manual plotting of ceph is all gone. Like this automatic landmark identification has nearly 95%. It is accurate to manual method of plotting. Similarly, model analysis. The time you just have to upload the scan of the models and your results is just out. Next is cleft lip and palate studies. N number of studies are done on cleft lip and palate. You can identify and diagnose the maxillary, the reason, the genetic and the environmental factors which is contributing to the maxillary defect. Now you can see a study done by Yang. Now Wong, and here he did a study where he took 60 CBCTs of 60 patients, and then he measured the height, length and width of the maxilla. And the upper row is how they measured the manual method of measuring the maxillary defects of unilateral cleft palate patient, and the row below is how they did it with a 3D unit model. And they noted that manual method as well as the 3D unit method, it was like 96% surpassing the manual method of plot identifying the defect. Next is facial attractiveness assessment. Now in this study, they plotted the points on patients, and nearly 69 Chinese orthodontists, they ranked the facial attractiveness from least attractive to most attractive. And they noted that using the support vector regression, the average coincidence rate was nearly 71.8 according to 18 verification tests. So in the near future, geometric morphometrics and a combination of support vector regression, this would be the best methods to identify facial attractiveness. Next is treatment prognosis prediction. Now what if a patient comes and asks, so you're asking me to do a chin cup therapy, would it be successful? Now for the answer for that, Bomi, they did a study for predicting the treatment prognosis for class 3 patients. Now what they did was a feature wrapping method, which is a combination of support vector regression and sequential feature method of algorithm. Now if the mandible was long, then they compared, like they took the AV plane to the mandibular plane, and if the angle was less, then the prognosis was poor. And if the defect was due to the maxilla was deficient, what they noted was the distance of A from point N. If it was increased, then the prognosis of your treatment would be poor. Then you can advise the patient to wait and do a surgical treatment. Next is treatment planning. Most of the orthodontists are in a dilemma whether you have to extract the teeth or do a non-extraction treatment plan. Now here you can see Z et al. They did a study, they did a back progression decision-making algorithm, and they noted that nearly 80% accuracy was achieved whether you need to do extraction or not. Another study done by Jai. Now here, he also did a study whether you need to do extraction or not, but in this study, this was a supervised study, and he had 4 classifiers. Now this first classifier was whether you need to do extraction or not. Second was whether it was a stereotypic extraction. Third was if it was for all 4s or all 5s. And the fourth one was for differential pattern of extraction. Another study for deciding about extraction. He also did extraction pattern, but along with that, he even did diagnosed the anchorage pattern that was needed for the patient. The last study for extraction decision was done by Mridul. Now, the usual conventional method of deciding if you need extraction was your model analysis. So she compared ANN with model analysis and noted that 65% was accurate for extraction cases and 62% for non-extraction cases. Next is choice of your appliance. Now, if your patient is a class 2 patient, you could give them a twin block, you could even give them a headgear. And even if you're going to give a headgear, you can give a straight pull, high pull, or a low pull headgear. So which type of a headgear are you going to give? So for this, OCAM, they did a study. They took the factors like overjut, overbite, and the mandibular plane angle. And the statement was, if A and B was 4.8 degrees, overbite 1.6 mm, overjut 6.6 mm, and the mandibular plane was 38 degrees, then you have to give them a high pull headgear. Now, similarly, even you can make customized brackets for your patients. Now, this is for my functional therapy, but then I'm just telling, even for customized bracket patients also, you can customize your brackets for the patient. Next is orthodontic surgery. All these 3 days we've been seeing in each and every session how much AI is used in orthodontic surgery. You can decide exactly accurate amount of cuts with the help of a corrector. You can 3D print the surgical splint, and even you can predict the surgery even before the surgery is done. Now this is a study done by Choi, and he did a decision-making back progression algorithm where whether you need to do surgery or not, whether you need to do extraction or not. So he had a 4-layer surgery like that, algorithm like that, and he noted that 97% accuracy was whether you need to do surgery or not, and 93% accuracy whether there was extractions were needed or not. Then the last one is 3D aligners. Everyone prefer a 3D aligners. Like before we had to motivate patients, but now patients are coming and asking us to do aligners. The start and the end of the algorithm is all completely market's secrets, but it is one of the best methods to move a tooth or a group of a tooth, but it has several disadvantages. It does not take into consideration the periodontal conditions or if there is any general disease in the patient. That type of a disease may actually be contraindicated. So just make 2 more minutes. Then it does not consider the facial aesthetics. This is very important for orthodontic diagnosis purpose. It does not take into consideration if you have any functional problems, and it does not have any link with the retention strategies, and several orthodontic tools like extraction, skeletal anchorage, and integrated restorative procedure. All these tools are not there in the software, and even all of you will agree that complex tooth movements is more better with fixed appliance therapy. So let's see the final study done by Bushan. Now here he compared the STL models of ClinCheck, post-treatment ClinCheck model which was predicted by that, and the real actual models, and he noted that there was no similarity at all. He had taken into account all these 7 factors. He did the ABO's objective grading system. He took the alignment, marginal ridge, inclination, occlusal context, occlusal relation, overjudge, and interproximal context. And he noted that what was predicted by the computer was actually not what was seen in the true post-treatment records. I keep talking about AI. The presentation would actually not get over. So this is the advantages, disadvantages, and what is the future of AI in orthodontics. Now, most of us, we know that AI robotic surgery is done right and left in neurological surgery, gynecological, and general surgical procedure. Maybe in the near future, even orthodontic surgery with robots will definitely be possible. And what is important is there will be less rate of infection, and the decision, and there will be more precise and accurate treatment we would be able to do. And the fear that clinicians will be replaced is always there, because the rate and the momentum of change in the field of AI is unprecedented, and there is a lot of change from the traditional signs and symptoms approach to precision medicine. Maybe in the near future you will get a system telling you suggestions like, if you want to tip the teeth, go and do tip edge mechanics. If you want to lose upper and lower top, then do a rock mechanism. So making it really simply super cool for all of us orthodontists to do treatment planning and diagnosis for patient. Thank you.
Thank you, Dr. Paul, for such a wonderful presentation. So, your final take on HI versus AI is what?
So AI actually is, we cannot neglect AI, sir. The future and the people expectation is all based on AI, but AI alone we cannot depend. We need the human intelligence also.
Thank you so much. Yeah, any questions from the audience? Thank you so much.
Thank you. Thank you, ma'am. I request our chairperson to give away the token of appreciation.
Thank you.
Thank you, ma'am. Our next speaker up here is Dr.